All right, cool. So my name is Eric. If I haven't gotten a chance to meet you yet, I'm a first-year medical student at St. Louis University. And I want to talk to you something about a startup that I've been working with for the past 9 months in St. Louis. It was founded about a year ago, and it uses something really simple. So just text messages and phone calls to kind of change the way that doctors and their patients can communicate with each other. So just a little background. When I showed up in St. Louis 9 months ago, I was a business student in undergrad, and I was really interested in entrepreneurship, but I had never really been involved with a startup like this. And I showed up in St. Louis, and I had no idea that there was such a strong entrepreneurship scene. And St. Louis is there's a ton of venture capital money being poured into the healthcare sector, specifically within St. Louis. And I think Joshua is going to talk a little bit about similar things going on here in DC, but also in St. Louis, there are incubators and tons of ideas between SLU and WashU and all the entrepreneurs within our community with great ideas for healthcare. And Epharmix is just one of these ideas. So Epharmix was started a year ago by some WashU medical students, so Washington University medical students, who just had one simple problem, or they were trying to answer a question. And that is, if you're a doctor, and we're all future healthcare providers, or we're policy workers, we're going to be thinking about what we need to know about our patients all the time. So when they're not in our office, what can we be doing to help them? And so if you could ask your patients whatever you wanted every single day, what would you ask them? And that's the essence of what Epharmix allows you to do. Just by receiving your patient's phone number when they're in the clinic, you can be signed up on our browser-based system. So there's no app. You don't need an iPhone to use it. And that's when I agreed to give this talk, I didn't know that the conference was focused on poverty and how markets and great ideas like Epharmix can be used to help the poor. But that's really what this system is about. This system is not for the rich or wealthy patients who have an iPhone or who have an app or who may already be really compliant and don't really need a system like this. But this is for the person with a burner phone who can't afford something better and who really needs their physician's attention. And we can use our automated systems to communicate with them all the time. All right, so as I've kind of alluded to, Epharmix addresses, so this is what's behind me is kind of our current medical paradigm, which is the acute care model. So you're the provider, you see the patient within the clinic or they're seen in the hospital, but after that encounter, so what we're taught in class is that patients forget 80% of what they're told, and they remember 10% of that remaining 20% incorrectly. So they walk away with about 10% of the knowledge that you tried to tell them. And that's another thing that our systems are trying to address. We want those patients to be compliant and to remember their doctor's advice. And so what Epharmix does is address that gap in care. So from the time they're discharged from the hospital, from the time when they're seen in the clinic, our systems for things like diabetes, for heart failure, for respiratory disorders, for people who have just had an orthopedic surgery in the hospital and might be at risk for infection, we can follow them and track their progress, their symptomology. All right, so the way it works, so the image on the left it's shown on an iPhone, which is ironic because I just said it works on anything. But so this is an example of our COPD system, and COPD, chronic obstructive pulmonary disease, people who have been smokers their entire lives, as I think a lot of us know, and they have really bad breathing problems. And so the way it works with COPD, it's one of our simplest systems, and we worked with pulmonologists at Washington University to build this. So you're a COPD patient, your doctor has signed you up in the clinic, and you receive a daily text message or a phone call, depending on your preference, every day at 9 o'clock, asking you if you're breathing better, worse, or the same. And if you say that you're breathing worse, then your doctor receives either an email, a text message, or a phone call telling the doctor or the doctor's team that this patient needs some sort of attention. And that's kind of the way that most of our systems work. So either they're alert-based or they're report-based. So something like an acute condition like COPD, we're trying to detect exacerbations. So COPD patients, they're breathing badly all the time, but oftentimes these patients end up at the hospital for weeks at a time to recover from respiratory infections and other periods in which they're really experiencing bad symptoms. So what we're trying to do by tracking their progress like this, by catching periods in which they're breathing worse, we can prevent them from being sent to the hospital, from going to the ED. They can be managed remotely by just being contacted by their doctor over the phone. All right, so some more background and about the back end. So what we're envisioning is that physicians right now pay $4 per patient per month for the system, and then I'll get into more of the financials of this later, but physicians can actually be reimbursed about $40 per patient once those patients meet some credentials for remote management afterwards. So there are financial incentives both for the physician and for Epharmix, obviously. But a key thing, another way in which the system is really equitable and kind of crosses all socioeconomic levels is that everything is toll-free to the patient. So it doesn't matter if it's an SMS text message or just a phone call, everything is free to them to use. All right, and as I said, but we're trying to cater to most of the needs of the patient and the provider. So there are tons of telemedicine apps out there, and really just across healthcare. There are lots of things that are being created, but not many things being used because they're not usable products. And so we're trying to work really closely with patients and with doctors to make systems that are usable. And so these are some images of what the provider would see. So the provider, most of our providers don't actually use our browser-based system. They receive the alerts to their phone, and they have a nurse that receives the alerts, and then the nurse can see the triage of patients, and they can see like red, yellow, green. Okay, this patient has reported breathing worse for 3 days in a row. We really need to contact them. Or these 10 patients have been breathing better for 10 days in a row. They're doing well. All right, and so we've done this for many different things. We have like 20 different messaging systems right now, and we're building more all the time. But the key difference between Epharmix and many other telemedicine interventions going on right now is that we're actually trying to prove that our systems work. They have a clinical effect. So every one of these systems is being tested in a randomized controlled trial. Right now we have 5 trials going for COPD, for heart failure, for diabetes, and for the ortho wound and decall. So we have an N of 500 in all those trials, and the goal is to show that we actually make a difference. And if we don't make a difference, that's unfortunate. We'll have to adjust, but we're not trying to make something that doesn't work. All right, so some more benefits for the providers that I've kind of alluded to already. But so one, we're trying to improve outcomes. So we're trying to keep people healthy. That is the primary goal of the system. 2, we're trying to make it easier for doctors. So we're trying to locate those patients who need the most attention. So when patients use the system, they're basically triaging themselves. So doctors can be notified of the patients that really need to be contacted for follow-up care. And finally, so there are new codes from Medicare and from other private insurers right now called chronic care management billing codes. And if a patient has 20 minutes of non-face-to-face interaction with the doctor's office, so if a nurse calls that patient several times over the course of a month, and they have a cumulative sum of 20 minutes of non-face-to-face time, that patient can be that interaction is worth $40 to the physician. And we can track that time for the doctor, and at the end of every month, give that doctor a summary of all the patients that qualify for the reimbursement. All right. So the next few slides are just kind of a summary of the benefits to patients and some of our data so far. So this is in the past year. So the thing we're most excited about is that patients really like to use the system. We're finding that a lot of these patients are very low income, and they're often very lonely. They're at home, and so when they receive our calls, even though a lot of the calls are robotic voices, which when I started I thought was really, one of the first things I said was, why don't we get a human voice and record the calls? But we got a lot of pushback from patients. They actually like the robotic voice, which I think is strange. Yeah. But they also just like to receive the calls. It's like a socialization for them, and they like to think that their doctor, even though the doctor isn't doing anything because it's an automatic call that's being sent from us, but every call or text message starts with, hello, this is a service of Dr. Sink, and then they get the questions. So they feel like they're connected with their physician daily. And so we're seeing really high compliance with the system. So these are patients who are on the system, they're receiving either a daily call, usually a daily or biweekly text message or phone call, and we see 80 to 100% compliance, which in a lot of medical interventions is really unheard of.
How big are your sample sizes?
So for COPD here, this is 20 patients, which was our initial pilot study, and it was pre the RCT that's going on now. And for diabetes, that's also 20 patients, pre-RCT. All right, so this is the same COPD pilot study that we ran, which ran from last summer to December of this year. And these are the 20 patients that were on it. And we saw that with time, which is something really interesting occurred, in that in the beginning, when they just were put on the system, they were reporting that they were breathing worse all the time. And then as time passed, they gradually stopped reporting that they were breathing worse as often. So there could be a couple different things going on here, but what we're hoping to show with our larger study is that these patients are actually learning how to better manage their disease. So when they report that they're breathing worse in the beginning, they're being hooked up with a nurse who might tell them, oh, you need to use your inhaler more often, or oh, you're out of your prescriptions, we'll call that into the pharmacy so you can get it. And so with time, these patients are actually improving clinically because they're more conscious of their disorder and they're getting the help they need more expediently. And so this is also, to Danny's point, a slightly small sample size, but this is one of the more amazing graphs. I mean, just looking at that, it's pretty drastic. So this is our diabetes intervention, and for our diabetes app is kind of like replacing the paper glucose journals. So many diabetics now are told when they go into the office, okay, start tracking your blood glucose values every day, bring it into the office the next time we see you. And our system automates that, so they receive a text message at 9 in the morning before they've had breakfast, and we get their fasting blood glucose values. And these are 20 patients who were on the system, and we saw just really drastic blood glucose control after just a few weeks on the system. And we're really excited about the results of our full trial of this coming out in a few months to see what that shows. I mean, because if these results hold up, this is just a text message that is having the power of a pharmaceutical. I mean, metformin can't do this. Yeah. Yeah, I mean, there are thoughts all the time about making it more complex, but we think that part of the beauty of it right now is that it is so simple. Yeah.
And semi-human.
And semi-human, yeah, robotic, yeah. All right, so just a few of the economic incentives, which I've really touched on already. So the short-term model is using those chronic care management billing codes, which might just be, because not every patient is going to qualify for reimbursement every month, but we're hoping that at least doctors who choose to use the system can break even, and they'll at least be, so that they're not losing money using the system, but they are managing their patients better. But the long-term goal is to get this as a covered benefit by insurers and to get large numbers of patients on the system to really stop or better manage their chronic conditions and start reducing things like heart failure decompensation events and COPD exacerbations, readmissions from the hospital due to infections, pneumonia. And so just kind of a plug for entrepreneurship in general, but I feel so lucky that I found this, and I feel really lucky to be in St. Louis where there's a community and there's infrastructure that is allowing medical students to do special things like this. And I would really encourage you, just don't be afraid to start something. If you have an idea, I really want you to run with it, and we can make a difference now. You don't have to wait, you can do it now. So I'd like to end just by asking the same question. If you had a tool like this, what would you choose to ask? That's it.